Sorry, I just realized I have 28C on here. This is exemplar 28D, suicide. We are not doing 28C, postpartum depression. That should have been covered last semester in maternal child. So we're 28D, and again, I apologize that it says 28C. This starts on page 1958 in your text. So suicide is the 10th leading cause of death in the United States. More suicides than homicides. Half the suicides were known to be depressed. Only 1/3 of U.S. adults screened positive for depression received treatment. Now notice that says 1/3 of the adults screened, because only anywhere from 20 to 30% are actually receiving treatment, and even when they're screened, they're not always receiving treatment or compliant with treatment. The half of the suicides that were known to be depressed, that's known by somebody to be depressed, but doesn't actually mean they've seen a healthcare provider for assistance. So suicide, here we go. I'll go next slide. Terms: non-suicidal self-injury, intentional self-inflicted acts of harm to the body tissue without the intent of suicide. You can think of things such as cutting that people do. Suicide itself is an act of inflicting self-harm resulting in death. So that's different than a suicide attempt. A suicide attempt is the act of inflicting self-harm with the intent to cause death, but not resulting in death. Suicidal ideation is constantly considering, planning, or thinking about suicide. So you're not going to ask somebody, are you having suicidal ideation or suicidal ideas? Be very specific. Have you ever attempted suicide? Have you had thoughts of hurting yourself or committing suicide or killing yourself? How long ago did that occur? Has it occurred more than one time? Do you have ideas of how you would do that? Have you put a plan in place? All of these are wording and things you must ask to evaluate the risk level for suicide. Sorry, I was just noticing in your text where it says that uninsured people of color and men were less likely to receive treatment for depression than women and individuals with insurance. That's a blanket statement. I don't know if it's less men seek help for it, or if they deny management of it, or people of color, whether, I'm not sure why that occurs. And I can tell you, individuals with insurance are more likely to get treatment because it's expensive. And unfortunately, without insurance, it is very difficult to manage to get the help that you need, because you need more than just medications. There's blood work, there's counseling. Okay, next slide. Genetics and pathophysiology. So genetics and neurobiology. It's the family aspect. If there's a risk is 5 times higher if a biological relative committed suicide. Think other factors, strong influencing factors: parental suicide attempts, early traumatic experiences, and decreased levels of serotonin. Well, the decreased levels of serotonin are going to lead to the depression. Interpersonal factors include history of some type of abuse, whether it's physical, psychological, sexual, combination of them, a history of rape, loneliness, recent separation from a significant other, grief from a death. Some events, interpersonal factors of events that can happen are unemployment, financial difficulties, loss of a home, or some type of other extremely stressful event causing despair. Comorbid disorders. Most common comorbid disorder for suicide are bipolar, borderline personality, conduct disorder, schizophrenia, and drug and alcohol dependency. Unfortunately, a lot of those disorders I just mentioned also have a drug and alcohol dependency related to the fact that they have this disorder. All of these disorders have impaired impulse control, depression, and make it difficult to manage in life, I guess is a way to say it. Individuals with bipolar disorder are 15 to 20 times more likely to commit suicide than the general population. Risk is decreased with lithium treatment. Many comorbid disorders, 90% who have attempted suicide have a comorbid disorder, which often involves depression, and half of those that succeed in a suicide are experiencing depression at the time or just coming out of it on the upside. General population has a 1.4% risk of suicide. Schizophrenics 10 to 13% risk. Those with an alcohol dependency 3 to 4% risk. Some social factors are recession, bullying, the dominant social beliefs, people that are experiencing discrimination or bullying due to being transgender, gender nonconforming. Female refugees from areas sustaining genocide need preventive suicide measures. Members of armed forces, veterans, homeless, lots of social factors. There's a section for you to read on page 1961, Suicide in the LGBT Culture. LGBT individuals 2 times more likely to attempt suicide than heterosexual. Gay and bisexual men are 4 times as likely to attempt compared to heterosexual. And LGBT individuals are more likely to participate in suicide attempts and ideation compared to completed suicides. And then the adolescent LGBT, very high rate of suicide, attempted suicide, and suicidal thoughts. That's such a difficult age anyway with a high suicide rate. So I will share, like with my son, is it the bipolar? And along with the bipolar and the risky behaviors, there were developed drug and alcohol problems and lots of social problems. His father was a very abusive, horrible person, so he experienced some very traumatic events very young. Even though I left at 5, the courts would not stop visitation. So unfortunately, he kept going back into that environment. And his first suicide attempt was at age 9, following a visit to his father. By the age of 12, I managed to scare his father into just leaving, but by then the damage was so extreme. And they also had social factors and lots of depression, lots of suicide attempts. And when he completed or actually committed suicide, it was probably 18 or 20 attempts in his life. He was 23 years old. He was homeless. He just got out of a rehab, was staying with me, but was having to leave within the next week. He couldn't find a job. He broke up with his girlfriend. There was just tons of things that added into the attempt. Okay. And it doesn't mean that somebody didn't know. He was uninsured, so he did not stay in treatment. When younger ages, when he was under my insurance, he would go in treatment. Lithium was a wonder drug, and he had such a good year of his life with that. Unfortunately, he would stop taking the medications because he said it would stop the swings, but he didn't stop him feeling them coming on, and the manic episodes were such a high that he described it as just this incredible, incredible high. So when he felt that starting to come on, he did not want to take the medication because he enjoyed the high of that. And then when he'd get in the depressives, he looked for other forms to get a high. It's a very, very sad disorder. Okay, assessing lethality. It is very important to assess the severity of their thoughts of suicide or risk for suicide. So when you're assessing their lethality of a suicide attempt, you're asking about their plans or their thoughts or their ideas. So there is, if they talk about taking pills versus hanging themselves or shooting themselves. Comorbid disorders, you're looking for bipolar or um, the borderline personality, um, conduct disorder, schizophrenia, drug, alcohol abuse, those other disorders that go with it. So risk factors. They have some listed in your text on page 1960, and I've expanded here. So risk factors: depression or other mental disorder, previous suicide attempt, family history of abuse, violence, or suicide, substance abuse disorder, suicidal behavior, firearms in the home because they have access to a very lethal form of suicide, social isolation, lack of support systems, recent unemployment, loss of significant relationship, feeling failure, hopelessness, history of trauma or abuse, chronic physical illness, including chronic pain. So you see where these are key questions when you're doing an assessment and obtaining a history to evaluate the risk. Some protective factors are strong family connections, community support, and access to mental health providers. There are lots of resources that are becoming available. Unfortunately, they're not as accessible as they should be. And there's still a huge stigma that with getting mental health help, that a lot of times it's not done because it is shunned by family members or friends or things like that. Okay, next page. Acute risk is path worn. I found this slide. It's also, your textbook has it on the bottom of page 1960. So is path worn? Ideation, substance abuse, purposeless anxiety, trapped, hopelessness, withdrawal, anger, reckless mood. That's a very good thing to help you. These are behavior cues. Signs of immediate risk are wanting to hurt oneself, looking for firearms or pills, talking or writing about death. Some other things may be giving some things away, not talking about the future, withdrawing from their relationships, purchasing a weapon. Okay, so some other clinical manifestations your text refers to are cognition on page 1961, a distortion of cognition, unusually rigid thinking, dichotomous thinking, magnification, overgeneralization, externalization of self-worth, and fortune telling. So this unusual rigid thinking. So on these, your text just lists them. It doesn't explain what they are. So your unusually rigid thinking is difficulty in changing the mindset. They're very obstinate. Dichotomous is thinking black or white, or another term is splitting. Cannot bring together positive and negative qualities. There is no in between. It's either the worst or the best. The third one, magnification. They put more weight on their perceived failure, weakness, or threat. More weight than should be, than it is. Fourth, overgeneralization. They depend on external factors such as other people to feel good about themselves, such as the professor didn't say anything about my response. That must be because I did a really bad job. Or he didn't hug me before he left. I think he's mad at me. Maybe he's seeing someone else, that sort of thing. Then the last one, hang on. I just realized I skipped overgeneralization. So overgeneralization is a faulty conclusion based on one example. Like failing one time at one thing means they're going to fail at everything all the time. It's very extreme. And then fortune telling is predicting the future in usually for a cognitive distortion. It's in a negative way. They're always saying the negative, that predicting that it's going to be bad. Oh, we're there's going for this drive and I know that we're going to get in a crash, or I'm going to get fired today. I'm not going to have enough money for this. It's going to rain. It's just going to be a miserable winter, that sort of thing. Hopefully that helps you because the text did not explain it. Okay, so collaboration. Collaboration in the text. Well, it starts in the bottom, page 1961. Oop, really is on 1962. You have your pharmacological and non-pharmacological. So pharmacological, antidepressants, mood stabilizers, antipsychotics, which we talked about antidepressants and some of the antipsychotics. I'm not going to go into them further. If I don't talk about a drug, I'm not going to test on it at this point, but these will be covered by the time we're at the end of mental health. Non-pharmacological therapies are cognitive behavior modification, which I've talked about before, and other kinds of therapy. The different therapies can be individual, a group, or family, a combination of all of them. Family therapy can help to bring together for both, for the person to feel that support they need, and also for families to actually understand mental health and mental disorders, mental illness, and especially after a suicide attempt, that it's not always they're just trying to get attention. A lot of times I've seen family members get angry with somebody after a suicide attempt because they don't understand the deep level that leads somebody to that point. What else? Patients who are at risk for suicide or have attempted suicide often benefit from therapeutic interventions addressing healthy coping mechanisms. There can be writing therapy, art therapy, other ways of expression to help them deal with everything and get a better grip on how to respond to factors in life. Lifespan considerations. In children, suicide is the third leading cause of death between the ages of 10 and 14. That is horrible statistics there. And most children in that age will commit suicide through hanging or strangulation. The black male children are the highest risk in that age group for suicide. Adolescents, it's the second leading cause of death between the ages, adolescents and young adult between the ages of 15 and 34. Adolescents will commit suicide due to a lack of meaningful relationship, sexual problems, problems with parents, bullying, harassment. Their brain hasn't fully developed. It's between the ages of 24 and 26 that the brain finally develops with the complete, what's the word? I can't think of the word right now, but it's the cognitive ability for complete abstract and concrete thinking, being able to really understand the finality of death. That it's really in that age, 24 to 26, before the brain can really grasp that. So I think that's why the suicide rates are so high prior to that. And then in the young adult, early 30s, so many factors in life can contribute. Another thing with adolescents is contagion, that other people doing it, such as celebrities, some of their friends, somebody they look up to. And then into the college age, there's anxiety about academics, new social situations, incredible amount of responsibilities. Pregnant women, it's not very common during pregnancy, but that risk goes up during the postpartum. Older adults, it is the seventh leading cause of death for over age 65. It can be unrecognized depression, negative events of their long life, terminal illnesses, just significant depression with losses combined with chronic illness, inabilities, finances, all those factors building up. During this pandemic, there has been an increase in all kinds of abuses and suicide attempts and suicides. So after this whole pandemic goes away, I think those numbers are going to shift, unfortunately, in a negative fashion. Okay, so this was a slide I found that I think is really good in your suicide attempt, a 5-step evaluation triage. Your text on page 1964 goes over all your things in your assessment and full patient and family history, focus on personal. This is a really good way. Safety. So you're safe, assessing risk factors, note those that can be modified, identify protective factors. This is your safe. Note those that can be enhanced. Conduct suicide inquiry. We've talked about determine risk level, interventions, like have they thought about it? Have they thought about it repeatedly? Are they consistently think about it in the past week? Has it been months before that thought came in their head? And where are they in that risk? Are they just thinking about it? Is it controlling their thoughts? Are they thinking about ways they could succeed with it? Are they giving things away? Have they actually put a plan in place? Have they thought about purchasing a weapon? What thoughts do they have on how they would complete it, and how lethal is that? Document everything in your findings. So this safety is also listed on page 1965. Document the patient's risk level and treatment plan along with rationales for both, why this should help and be effective. Almost done. Diagnosis, again, I have listed here. They're from your textbook in page 1965. Your planning, again, pulled from your textbook. Remain free from injury. Ask for help when needed. That always needs to be part of your planning. Discuss any extreme feelings or depression or hopelessness. Participate in regularly scheduled therapy. Demonstrate healthy coping mechanism. Begin to demonstrate a desire to live. That's very, very important. Implementation. Again, making sure everything matches what you see, what you diagnose with, plan for each specific diagnosis, how implementing something that will bring to effect that plan, and promoting immediate safety. Your text lists ways, things to do here. Also, read box 28.5 on page 1966, no harm contracts. That is very important in documenting, and it may sound silly, it's here number 4, no harm contracts and safety plans, box 28.5. You make a contract with the person, or they should make a contract and a safety plan in writing, and do that with somebody, whether it's with you as the nurse, with a family member, with a therapist, but they need to have a safety contract and safety plan. It actually is effective. It's not a guarantee, but it does decrease that risk. Evaluation. Oh, hang on, I think maybe I need to add some stuff here. Promote immediate safety. No access to lethal means, never left alone. Alert the appropriate people. Number 2, increase patient knowledge for them to be aware of symptoms of depression. Educate them on their medications. Educate family and or concerned individuals. Include telephone numbers for the National Suicide Prevention Lifeline. That is really important. I keep saying how important these are, as in the time I've worked as a nurse practitioner, I have dealt with so many of these that these steps actually are effective. As number 3, assess and monitor for self-injury behaviors. There are non-suicidal self-injury behaviors. That's what you want to focus on. That's in your no harm contract and safety plans in box 28.5. Examples for harm and no harm are cutting, bruising, burning of the skin, hair pulling, which is called trichotillomania, hair pulling, interfering with wound healing, extreme nail biting. Okay, sorry, just had to add that in. I just went right past it. And then your evaluation. Remain free from injury, verbalize emotion concerns, enter a substance abuse program, participate in all scheduled therapy, demonstrate effective coping skills, seek help when needed. So when you're writing this up on a plan, they need to be specific and measurable. You're going to put a time frame on these things, specifics that the person is going to do, not say within this shift they're going to demonstrate effective coping skills. That tells me nothing. That is not specific. So name one coping skill that this person will demonstrate and verbalize to you or show you. You have to be able to measure it. Okay, so again, there's a nursing care plan for a patient who is suicidal, which is very helpful for you in implementing and establishing how to implement the nursing care plan, the nursing process, and the concept map. That is the end of this recording.